and the number of webinars being what they are, it's very difficult to take time out of your schedule. So we hope to make this meeting certainly worth your while. All right. So, Tim, do you want to just give a quick review of some of the things that we learned from OMH last week?
Yes.
Okay.
Yeah, and so we had a very productive meeting with it, OMH, in that they were honest in terms of the challenges they're facing and some of the decisions they have to make, and particularly related to their relationship with the federal government through DOH. So the first, and I think the most important one for our waiver providers, is really conflict-free. And we've been following this very closely. As you know, the CMS has really wanted a very strict definition of conflict-free that meant that an agency doing care management would have no relationship, no financial interest in any of the providers that did the services. And the state has been pushing back on that because it certainly affects not just our waiver, but B2H and the whole health home and HARP and all of the services. So this is very important for us as providers. Now, interestingly enough, they have had regular conversations with CMS over probably the last, I don't know how many months, but those conversations have pretty much stopped. And CMS has not rescheduled those what was once weekly meetings. And that is concerning in that it doesn't really tell us which way CMS is moving. But what we did learn is that OPWDD submitted a plan that really met 100% of the federal rule. And so again, that's very concerning. I think we need to get more information about how they're planning to implement it, but it really is going in the wrong direction. Any questions about that?
And Jim, the only thing that I'll add is that Meredith, at the time that we met last week, had not even heard about our 1915 waiver, C waiver being extended, and the date that it was set to expire is September 15th. When I checked with her yesterday, we do have an extension of the current 1915 C waiver through December 15, 2016. So CMS did provide the authorization to continue our program. So from that perspective, through December, we can expect that there will be no changes to the waiver program.
And it's important to know that the extensions can only be limited to 3 months. So there's nothing implied by having it through December, but because that's the period of time that these things are extended. Okay. They also talked about the new SPA services. And again, the SPA services are a critical part of OMH's and DOH's plan related to supporting and improving health care status of kids and families. And, they put together a list of SPA services that I think many of us got excited by. Now, the problem is CMS does not allow delivery of the same service or similar services under 2 different payment approaches. So there's a large overlap between the services that waiver provides or B2H provides and the new SPA expecting is that OMH, DOH will only be able to implement one new service when that takes effect in January, and that is the one of other licensed professional. And I guess for me that means that it allows other licensed professionals to provide some services, but beyond that I'm not sure the implications and what opportunities does it provide, if anything, to both families and providers, because I can't see anybody really ramping up for these new services with just such a limited range. Andrea, I don't know if you want to add something about that.
Well, the only other thing I wanted to add was a question that I asked OMH, and it was that recently I shared with you and OMH shared with the clinic providers the new guidelines on LMHPQ services, which allow licensed mental health professionals affiliated with a clinic to provide services outside the clinic four walls and to get reimbursed at up to 150% of the clinic rate. And that's a fairly great flexible benefit that you can start offering right now. But in the end, it's very similar to the OLP service. And yet the OLP spa service, we don't know the rate, but I'm expecting it's not going to be as high as that LMHPQ rate. So I asked the question, were they concerned that, providers that had clinics would opt not to do OLP because they could do the similar service and get reimbursed at a better rate through their clinic, and they acknowledge that they are concerned and they're having discussions about it. So this is the first time that I personally am less enthusiastic about the new spa services because I feel that while the proposal is very exciting, I feel very confident that clinics are going to do a great job being able to provide services off-site, and I'm less convinced that we are actually going to be expanding capacity through by designating new providers to do these state plan services. So I'm just trying to read the tea leaves here, but I became a little bit concerned about the future of some of these services at this meeting. So does anyone have any questions or comments?
We do have a couple questions. From David Goldstein, we have, are we aware CMS ruling on COI in states other than New York that have similar waiver type programs?
Yes, we are. So we learned from CMS in the regional office that many other states are having difficulty with the conflict of interest federal rule, but CMS has not waived it or backed off implementation. So other states are trying to implement the transition plan, similar to a transition plan that OMH would have to implement to comply with the rule. And I'll just go over a couple of the ideas that obviously OMH has shared with us and with CMS about how they would try to comply with the rule, many which are very disruptive to this provider community, but their proposal is very similar to what other states have done. First of all, the other states have applied and successfully been granted a waiver of the rule for providers in very rural areas where there would be no ability to comply. And OMH does and has tried to collect some information that would allow them to submit for that rural exemption. Secondly, they have proposed a time period by which there would be a transition to compliance. The proposal for OMH was, relatively short, 3 to 6 months, and then recommendations about how to ensure that populations that are served by an agency but not by their care coordinator. This is the concept of sharing your service provision with another provider, where they would do care coordination for a certain population of kids and you would provide the services, and then they would provide the services for a certain population of kids and you would provide the care coordination. So other states are in compliance or are transitioning to compliance, and no other states have been granted an exemption to the conflict of interest rule.
All right. David, if you have a follow-up question, I can unmute you if you write in. We have another question from Audrey Lafrener. Her question is, do we have clarification that OLP is provided under Article 13, Art 31 clinic for a billing method?
No, OLP can be provided, once it's designated as a spa service, OLP will be provided under the designated providers. It doesn't have to be provided by a clinic. My observation is that OMH just recently gave clinics the authority to do licensed mental health practitioner services off-site, and that ability is very similar to, what will happen under the SPA. So I'm not going to say it's duplicative because it could be different providers. The designated providers might be people who obviously don't currently provide clinic services. And that's how OMH explained it to us. They explained to us that the vision of the SPA services was to create a bigger tent and to bring more people in. And that was the excitement around the designation. But the next item on the agenda is some concerns about designation, and in addition, some concerns that we've expanded the authority of clinics to do some of the very similar things as the SPA, and will that be a disincentive for people to get into the new SPA service business? I don't know, Audrey, if that doesn't answer your question, Nicole, you can unmute Audrey and she could follow up.
I will. Sent you your audio pin, Audrey? That in, or you can type back if you're having any issues. But other than that, I have no other questions. Yeah. Oh, there she is. Audrey, would you like to respond?
I was just going to say that was a helpful clarification, because I think that point that the spa services will help expand capacity. If people don't have clinic licenses, that's really the angle, I think.
Yeah, and that's OMH's intent, but they are starting to see where there are some gaps in their logic. And I raised one of them, which was the LMHPQ rule. And I hope all the clinics are doing off-site licensed mental health practitioner service provision, because that will expand to the House City now. We don't have to wait for the SPA service.
Thank you.
Yep. All right, Jim. Another question?
More questions.
Sure, go ahead.
From Karen Richmond. So will there be an increase in waiver slots to meet the needs of additional kids?
Yes, waiver will become uncapped. It's not an assignment of slots. It's just a designation. As many providers that are interested in providing the new 1115 waiver services, and the services are unlimited. They're just available to any Medicaid-eligible kid who meets the level of need criteria. So it's better than an expansion of slots because it's completely uncapped. It's based on need, and it's available to any provider who wants to become designated. Not as concerned about that designation process as I am about the SPA designation process. I feel like there's some disincentives to the new SPA services kind of cropping up that hadn't been thought of before.
I have another question from Sharon Mahota. Going back to OPWDD, it's taken years for them to come into this compliance. Is there some ground precedent for the time it would take to comply?
They also have proposed a transition. Good question. But I guess the way it was explained, and I don't know the OPWDD system, so there are providers on the phone that are going to be much better versed about this than I. But the way that it was explained to us is that they already use a lot of grassroots, individual provider type service provision, and so it's less service provision by agencies. So the agencies will do the care coordination, but they'll do this subcontract with individual providers for the provision of service, and therefore that's why they felt that they could easily come into compliance with the federal rule. And if anyone has any insight to say that that's not why it's easier for them to come into compliance, please let's inform each other.
This is Jackie, Andrea. I don't think they think it would be easier, but I think the proposal was taking the MSC coordinators and establishing them under another entity so that they could then contract out. But there's still some, I think, confusion and discussion as to how exactly that would be done if there's to be no financial linkage back to the provider agency. So there's been discussions about regional networks, maybe coming together regionally and forming an entity that provides MSC services, and there may be other models that they've discussed that could bring MSC services together, but there still seems to be, that gray area of, well, how does that work for provider A and provider B if they can have no financial stake in this, or are we really talking totally separate agencies similar to like home care, where you would be contracting with maybe for your licensed personnel a totally separate, corporation, and there would be no financial ties. So it's still, I want to say, from the providers that I've talked to and the provider association, it's still, there's a lot of unclarity at the, at this time.
Let's suffice to say OMH and possibly even DOH was surprised. I don't know how surprised, but OMH was surprised that DOH allowed OPWDD to put in a proposal with 100% compliance when everyone else was arguing against it.
Agreed.
It doesn't help us, though. So, because OPWDD is the biggest waiver in the state. Our waiver programs are small compared to OPWDD's. So, wow, this meeting's just getting off to a very uplifting start.
So let's go on to the last part of that. And basically, what they've done with the adult system for these new services, they had people apply to be designated providers. And when it came, and they were asked to do that without really understanding any standards, without having any rates. And when all of that came out, a lot of the people who were designated, the providers, basically said, I can't do this for that. And so you really had a false list of provider in the network. And we're asking OMH to really delay doing any designation until we have better information about rates and standards. And they're taking that under advisement. Is that accurate, Andrea?
Yes. We feel strongly that families don't need to be misled about really robust new networks for the SPA services and the 1115 waiver services. If there are large numbers of designated agencies, but there's actually no one prepared to provide the service, we think that both the plans and the populations that need services will be better served if we actually go through this process fully informed and the people who get designated are serious about providing the services. And so we had a frank discussion about that position, and there was no resolution about it, but as you know, OMH had indicated that the designating forms would be available this summer, and they are not yet. And I would suspect that after the discussion that we had, you don't need to keep checking your email to see them in the next few weeks, to find them in the next few weeks. Does anyone have any questions about designation or any concerns about the position that the coalition has taken on designation?
No, I haven't got anything in, but Sharon had commented back. Our experience on the ground is that there are not many of those grassroots providers.
Yeah.
But no questions moving forward.
Okay. Oh, did I go too far?
Yeah.
Oh, okay. I'm trying to go back, Nicole. What do I do?
We're the public policy forum?
No. How do I go back? See? No, that didn't work. There I go back. Okay. Let me make sure that this is, yes, the public policy forum. Thank you, Jim. Thank you.
Well, and I think it's important to have something positive and uplifting. And so on October 19th at the Gideon Putnam, the coalition is putting together what I think is one of our strongest public policy forums to date. And we have an all-star cast. So why don't you talk a little bit about it, Andrea and Jackie, and really what I'm encouraging people to do is really reach out to your network, to your local officials, to really get people to attend and try to get high-level people to attend this. So why don't you talk
I'm going to bring up the actual program and just walk through it with people. So we are focusing on value-based. We will introduce to you, our membership, the new Assistant Secretary for Mental Hygiene in the Governor's Office, Megan Baldwin. Some of you may know her. She was the health analyst with the New York State Senate. No political commentary about why people that work for the Senate Republicans would be going to work for the governor. You can draw your own conclusions. She's very good. She knows Medicaid. She knows health care. She's going to be a big asset to trying to bridge the negotiations between the Department of Health and, the behavioral health community, I believe. The first workshop will be a framework for value-based payment strategies. The commissioner will participate and share her thoughts. Kate Breslin, who co-sponsored the United Hospital Fund recent report on value-based payments and on specialty populations, will participate, and Doug Fish from the Office of Health Insurance Programs will also participate. Then we're going to have a workshop on quality outcomes and the long-term impact on children's health care based on quality and data, which is a priority that did come out of our board retreat. And then after lunch, we will have a very frank, open discussion between the managed care plans and our providers about, what managed care for children's behavioral health will participate in. You see we have Bruce Feig from Sachs Policy Consulting facilitating that conversation, and Fidelis, Beacon, and United, which are some of the biggest managed care plans in the state. So registration forms will go out today, and we hope to have a really great cross-systems representation at the policy forum. And I know that it's hard to travel, but we hope that beautiful fall location of the Gideon Putnam in Saratoga will entice you to come out for the day. Plus a great lineup. Any questions on that?
I wasn't sure, I was muted, but I do have a couple comments.
Yes.
Here. From Stephanie Burke, and she wrote, back to OPWD, I hear many small counties in my region that OPWD waiver has very few providers to provide the direct care services. I believe they're in a similar position that we will be with conflict-free.
Right. So, Stephanie, I do think that OPWDD does plan to access the rural waiver exemption for those circumstances as well, so that providers would be able to provide the direct care services as to their clients. Care coordination agencies would be able to provide services. I mean, that is part of the federal rule, so that is an option for everyone. I mean, the problem is that you'll continually have to justify that no one else has come in. And I guess at some point the feds could decide that, we aren't trying hard enough. I don't know. But that rural exemption does exist, and all the waiver programs plan to take advantage of it. Anything else, Nicole?
Nope. I just, Sharon had commented back on when you had answered her, and she had said, our experience on the ground is that there are not many of those grassroots providers. But that's all.
Okay.
All right.
And then, Jim, just to touch back with the membership about our board retreat in July, since this is the first time we've been back together since that.
Yeah, and I think what's important for the members to know is that really over 2 days we had very robust conversations among the board members and some invited guests about how do we help our members get ready for the new environment, get ready for the future, when we've really been under a very difficult financial times, when we haven't seen financial increases since 2008. There have been reductions in some cases, and with that we've got all of these new initiatives going on, and in many ways our agencies are really struggling to really have the capacity to prepare. And so with that, we've identified a series of issues that we want to work on. And the first, and we spent a lot of time, is workforce issues. Clearly, there is several things going on that are going to create some stress for our providers. And the first one is the minimum wage going up to $15 an hour. It ramps up quicker in downstate than it does upstate, and the state has in fact tried to address that through increases in rates or increases in contracts. However, we all agree that the bigger concern is the federal change in the definition of an exempt versus the non-exempt employee, and that's scheduled to go into effect December 1st. And I think most of us are very, very concerned about that. Clearly, the answer is, well, you need to control overtime and manage that, but that becomes difficult when you have programs where people are committed to providing 24/7 support to families in the community. And so when the family's in need, we say, we're going to go address that. We're going to go out to your home, and so you're spending a lot of time in the field. You need to be flexible. So there's a lot of concern about that. I don't think the state has really recognized it, or if they have, they basically are in denial and try to focus on the $15 an hour issue. So we really want to do more advocacy about that and continue to kind of let people know that this is coming up quickly. It's going to have a serious impact. And also, you know, we need to have some conversations among our providers about different ways we are of addressing the issue. So that was one issue. Workforce is being very important. Anything from people who were at the retreat, do they want to add on that particular issue? Okay, I'll go on unless, Andrea, you still there? Hello?
Yep, I'm still there.
Okay, good.
No, I mean, obviously the coalition is working closely with HSC and FPWA. They are still focused on the 15 in funding, but I think I participated in the Albany Regional upstate tour that they did, and I think that they got the message that it needs to be more, they need to broaden their advocacy beyond the 15 in funding. So hopefully we will have a big net of nonprofits working on the workforce funding issue. And then the other priorities that Jim, you know, we just discussed that the Medicaid managed care transitions and the cash flow issues have to be the mechanics of what we advocate for. The programmatic advocacy is one thing that the coalition has strengthened, but we need to strengthen our advocacy around funding the transition, adequately funding the ramp-ups, and just the payment mechanisms and the relationships with plans so that delayed payments aren't a big issue. So that's really what came out of the retreat that the members should know we will focus our efforts on.
Okay. And then the other issue that we spent a lot of time is really how do we strengthen the children's voice in this time of transition, and it's really addressing, I think, many of our agencies who belong to multiple coalitions, and the coalitions were all, including our own, were all developed at a time when state agencies really had control over both budget and program decisions. And it's clear to us that those state agencies are significantly weakened, that they are not a huge player in this transition, that it's being held by Department of Health. There are new programs, there are new services, they're all going to be paid for eventually through managed care, and so that we have to come together and develop new partnerships and really find ways to really strengthen the children's voice. There is nobody out there who really is speaking for children in the same level that we are on the behavioral health side. And so we really have committed ourselves to developing partnerships with the other coalitions or doing something differently if necessary. And so really bringing together the large agencies to really have influence in the way in which our coalitions work together on these issues is an important priority, and we will continue to do that. We think that there are a lot of common areas that we can be working on. Workforce is one of them. The FEGS report and the whole underfunding by government of the support necessary to be successful. So there's a lot of common ground, and we've got to do a better job as the variety of coalitions of working together, and that's really been a commitment.
And Jim, I'll do the last one because I actually have good recent examples as recently as this morning. So, you know, the coalition is always available to our member agencies to help you understand anything. Sometimes that doesn't quite feel like boots on the ground, but two things that I think, you know, we want to make sure that the members do feel supported. And I got a request this morning, you know, can someone really explain what the new spa services are and what the new 1115 waiver services are? And when we did the transition age youth focus group at one of our provider agencies, and we brought in like 4 member agencies to have a small group discussion about the new services, it's so much more productive in a small setting where people can ask the questions and say that the 2-hour webinar by MCTAC didn't help them understand what the changes are. And you know, we want to be that resource for you. And you know, it was discussed at the retreat, how can we get feedback about what the information that our membership needs to really be successful. And, you know, I'm just making the commitment that, you know, Jackie or I can come to your meeting, we can talk to your staff, we may consider doing small regional meetings where we could get 3 or 4 member agencies in the room and talk through with you what the services are that are going to be new to the system. We don't want you to feel that you have to figure this all out by yourself, or that because I put a link up on the PowerPoint that you're going to go and interpret it, you know, alone. We want to be able to help you do the interpretation. So we'll talk a little bit more about some examples of how we can do that as this meeting unrolls. All right. So.
Okay, so you want to go on to the next part?
Yeah, unless there is any questions, Nicole?
Nope, I have not gotten any more questions.
Okay. So yesterday, in an example of OMH isn't driving the ship anymore, DOH is, I reported to our membership that after the budget negotiations last year, when DOH was very reluctant to agree to the APG extension, until DOH felt that OMH was committed to moving the system forward and really engaging in managed care transition and the development of value-based payment, they created a monthly meeting of high-level Department of Health staff with high-level Office of Mental Health staff with all the behavioral health trade groups. And I have attended every single one of these meetings. Yesterday's meeting was not really to ask our opinion about a budget proposal, but to tell us about a budget proposal whereby OMH and DOH and OASIS have decided to use the existing value-based payment framework to collaborate with managed care organizations, and that they want to provide resources for value-based payment readiness to behavioral health service system so that the MCOs will administer the VBP readiness investments. So the money is going to go through the plans. And the reason why we were being told about this is because the budget that has to be developed for the rates that go into effect April 1st is now under construction. That's always the way. The budget that the governor proposes in January gets developed between October and January. And the Department of Health is in its last phases of negotiations with the plans about what will be in the premiums come April 1st. And so this proposal is one of the last things that they will be discussing with the plan. So to the extent that people didn't support this proposal yesterday at the meeting, I didn't get the impression that it was going to change the fact that it will probably be in the budget. we might have the ability to lobby against it to the legislature, but I just want to make everyone aware this was the message, that in order that value-based payment includes a significant amount of behavioral health in the payment methodology. So the value-based payment methodology, right now, the department doesn't feel has a strong inclusion of behavioral health community providers. And so plans are going to, be responsible for what percentage of value-based payment contracts they have. And so they want to incentivize the relationship that the plans have with their value-based contractors by making sure that the networks include behavioral health providers. And so there's going to be $60 million over 2 years, $5 million over 2 years to help create IPAs or accountable care organizations, or the payment infrastructure that lets you meaning community-based providers, be capable to accept payment and risk. So that's some technical support money, boots on the ground for you to hire a lawyer to review an IPA contract to make sure that you're getting the best deal if you decide to go into an IPA, and then some funding to create the IPA. That was an example given. And then a second pool of money, $17.5 million for each of 2 years, where there would be funding increases to make sure that the behavioral health community providers are included in the value-based payment pool and getting enough funding to make sure that they're healthy and a good contributing partner to the program. And then there would be $10 million set aside for each of 2 years in a reserve pool to address unanticipated gaps, in services and in participation or investments, to make sure that you're actually managing the risk, or your system is accepting the payments, or any other cash flow issues that might come up. So this was presented just yesterday. But I guess the third bullet here on my PowerPoint is that my interpretation message is that large, diverse networks that are incorporated to accept value-based payments are sought by the plans, and that the plans want to do business with the fewest number of payers. And if they are going to buy into and be held accountable and be penalized if they don't have value-based payment contracts, they want the state to invest in the creation of robust value-based payment readiness. And this isn't just about you, behavioral health provider, creating a behavioral health network. That's not what the message was. This was you, the behavioral health provider, along with the largest pediatric practices in your area that serve your kids, creating a kids, payer, a kids provider in a non-traditional sense of the word, a kids provider network that will take one payment and it will go through some kind of fiscal intermediary that will then pay you for the services that you provide. And I know that this is a tremendous amount of information, but just let me be clear. I'm just giving you the message. We can develop a strategy about whether to support or not support this. But DOH is moving ahead. They're not backing off the second step. We haven't moved into Medicaid managed care yet. You don't even have contracts yet with Medicaid managed care providers. But in some ways, skipping over that step and getting into a value-based payment situation could be better, because as the plans move forward, their percentage of value-based payment contracts is going to be a ratio of regular managed care contracts to value-based payment contracts. And as that ratio gets incentivized by 2019, if they have to have 80% of their contracts value-based payment, they will not want a high number of just regular contracts with a single provider. So that's a lot, and I'll stop there and see if there's any questions.
One question so far. Hello?
Yes, go ahead.
Oh, I'm sorry. It's from Ken Olson. What is the likely impact of this initiative on health homes for kids?
Ken, that's a good question. I did point out that health homes, you know, some of our providers had stepped out and made decisions, business decisions around health homes, and then found out that, you know, the conflict of interest decision may negatively impact those decisions. And our health homes intended, could OMH and DOH get a clear-cut answer about whether or not value-based payment overrides conflict of interest? Because there's no incentive for us to get involved in another network whereby it restricts our ability to get care coordination paid for, because we're also providing services, even if they're not the waiver services. I don't know that that's true. I'm just saying I asked OMH for an answer. I asked DOH to clarify to what extent conflict of interest affects anything related to value-based payment. So that question is pending. We didn't get an answer yesterday.
And we have another question from David Woodlock for comment. The networks Andrea just references are in the main thought to be the disrupt-related ones as an example.
And I think that that's true, David. I just wonder that if, you know, are the district networks, you know, prepared to really include everyone in their value-based payment contracts? And, you know, is it worth having a discussion with the plans about how many smaller components other than the district networks they would be willing to tolerate? And that's something that we can talk about at our policy forum, I think, openly with the plan. So because the district networks didn't kind of meaningfully include children's behavioral health, is there an incentive for us to create additional components that specifically address the child population? And I think that that's a good discussion point. Although obviously I think the plans are thinking the district networks would be nice because they included everyone. I just don't know that the hospitals are really prepared to pay everyone, you know, do take on that administrative role of distributing or creating an IPA, the legal cost of creating an IPA. And could it be possible that maybe the coalition and the FQHC, you know, try to do something on a smaller scale just for kids, or the biggest pediatric hospital provider? And downstate, I know that that's kind of, there's not just one provider, but I'm going to put up, actually I'm going to skip over and I'm going to go to this slide. So one of the things that I think is a first step that our members really need to understand is, where are the kids for their health care? Because this slide, which has been used over and over again in PowerPoints that you're probably halfway paying attention to, identifies all the children in the states who are enrolled in Medicaid managed care, 2 million kids. And it breaks down by plan, by Medicaid managed care plan, how many kids are in each plan. And what we need to try to do is figure out where those kids are receiving their primary care. Where are the biggest pediatric practices, hospital-based pediatric clinics, FQHCs? Where's the bulk of the kid population? Those should be, those should be our partners in moving forward with value-based payment. And I don't know, whether it would be worthwhile for the coalition to get this breakdown requested as a freedom of information, or just as a first step in moving forward to try to show OMH and DOH good faith. But that's something that maybe we should try to do before our policy forum, is to really drill down into these numbers where the where the natural partnerships might be for specific managed care plans.
We had more comments from Elliot Klein. He says, we attended the VBP boot camp yesterday, and they said the payments would flow through the MCO, and it was in their full discretion if they want to pay providers or not. It was made clear that the MCOs were not under any legal obligation to pay.
To pay for services? I'm not sure I mean, I suppose that that's true, but let me just try to interpret your question, Elliot. Can you?
I can
unmute him.
Find him on here and unmute him. Hold on one moment.
They're not.
Elliot,
They're not
I've
required
unmuted
to
you.
play.
Yeah, I'm
go
here.
ahead, Elliot. Yep.
Okay, so actually Karen was at the meeting for me, but I spoke to her this morning. It made it sound like the MCOs were, even if we followed everything and provided the services and saved money and followed all the new protocols, that they were not under obligation to pay us. I don't have clarity on that, but it sounded a little disturbing. So I just want to put that out there.
I think that that's a great question, and I'm glad that you attended the boot camps, because that's kind of, I really want to encourage people. There are going to be two specific, the boot camp information I put up here, but there are going to be two specific children's value-based payment presentations by MCTAC, September 21st and September 29th. And I hope that our membership will engage in these, because I think that the more information we have, exactly to Elliot's points around the exact discretion. Elliot, I'm going to interpret what you heard. The value-based payment models, that there is no commitment for the MCOs to pay individual providers except through the VBP. So the payment, the way it was explained yesterday, the payment would go to some entity like an IPA or an ACO. The managed care company would pay that entity, and that entity would have a contract with the providers that actually provided the service. Here we have another example of some delays in payment that are very disconcerting. But I'm wondering if that was the discussion that you heard at the VBP.
Right. I don't know. Like I said, Karen Krampus represented us at the meeting, so I don't know.
Okay.
But that was what she told me this morning. So I can find out further, and we can talk
Yeah.
offline.
Yeah, that would be helpful.
Okay. Thank you, Andrea.
Anything else, Nicole?
I have no other comments, but I see David Woodlock, your hand is raised. I have unmuted you, David, if you'd like to comment on your...
I think that was just left over from before.
Okay, I will keep you muted. All right.
So, David, let me just ask a follow-up question. Are you suggesting that the district networks, become legal entities to take the payment, or what? And then what I'm proposing a little bit different than that. Is that what your suggestion was, though?
Well, I mean, I think a couple of things. One of which is I just think the infrastructure required to manage a large network that is managing individual per member per month expenses is really extraordinary. So you know, there's the legal fees, et cetera, associated with setting up an IPA, which is, in my opinion, sort of a drop in the bucket compared to the administrative infrastructure and skill set needed really to manage, I don't pick a number of 1,000 or 10,000 people's expenses almost in real time,
Yeah.
you know, across a lot of different sites. So the prospect of doing that in a meaningful way is I think really daunting. So the notion of using the large, pretty sophisticated, already existing networks and infrastructure of large hospital systems at least appears to be a more facile path from an administrative point of view, which does not negate in any way at all that, you know, the real engagement of those hospital systems and the PPSs with you know, with any behavioral health providers is very nominal. So I think both of those things are true, and that from the managed care company's point of view, you know, the fewer the better. So they don't particularly, because it costs them more money to be contracting with multiple networks even. And I think then the last part of that discussion, at least to keep in mind, is that I have not heard any clarity, and have asked a number of times if in fact the state meets its requirements to CMS if the managed care contracts are with these hospital systems, that many of which are starting to be ACOs, if those are value-based payments, and then they can then contract with people in their network to remain on a fee-for-service basis, if that really comports with CMS's requirements. Because that would be an easier lift for everybody to simply remain in a fee-for-service relationship with an ACO, and the managed care companies having value-based payments with the heads of those networks, whether that's an existing PPS or it's a new ACO or something like that.
Right. So that was exactly the type of discussion. We have to drill down in what the best models are for the behavioral health community providers. But OMH and DOH totally believe that the behavioral health community are not engaged sufficiently in value-based payment arrangements and are not fully informed about how value-based payment work. And I think if you ask that question and they don't know the answer, it behooves us to push to find out the answer and to design proposals to our, you know, whoever we identify as the entity that we would most likely want to be doing business with. But I think that my message today is, if we aren't engaged in value-based payment arrangements, it is going to put you at risk during the next iteration of contracting with MCOs. And next iteration, I mean, you know, 2019. So
I agree 100%. Yep. I can tell you, Andrew, and for what it's worth, there are two value-based payments pilots right now out of, I think, the dozen that are in play right now that are related to mental health and the heart population. One that's sponsored by Mount Sinai and one that's sponsored by Maimonides down here. And those are the only two mental health pilots that are going on right now. And we're involved in both of them. And the staff here have to periodically get on the roof to keep me from jumping on it. So
it's a lot of fun, you're saying?
It's the complexity is beyond compare.
Yeah.
So David, is that really what you're saying? Is I think it reinforces that really the hospitals really have the infrastructure to manage this, and we'd be in a position of having to create that infrastructure if we were doing something outside a hospital system.
Correct. Yep. Now, you know, the whole other question is why a managed care company, on one hand, would want to give that much control over authorizations and continued stay reviews and all the rest of that to an ACO or a PPS is another question. But they've been doing that a lot already. You know, I mean, Northwells and Montefiore are already insurance companies, so they do that all the time.
So this is just a preliminary update on the discussions at the state level. The follow-up that I had after the meeting was that this investment primarily is a reinvestment of some actuarial errors that were made in moving money into the premiums for the HARPs, and was the state envisioning using some of the adult reinvestment money for kids' value-based payment readiness, and DOH and OMH indicated it's possible, but they'll get back to me with an answer to that. They don't intend to leave the kids out of value-based payment readiness. So whether we access this $60 million or there's some other resources earmarked for value-based payment readiness for the kids' behavioral health system, that's a separate question. But behavioral health readiness and inclusion in VBP payment systems, arrangements, is a priority. So I just wanted to make sure people know that. And I hope that people will be able to at least get on the two, up on the screen now are the two CTEC VBP proposals or workshops specifically about children's mental health. And those are September 21st and September 29th, and you can go to the MCTAC website and register for those. And the coalition will try to do a summary of what we learned from those so that the membership is informed. So I think we just had member feedback on value-based payments. Does anyone have any other questions? And again, if you attended the boot camp, or like Elliot had a question, ask me the questions. I will get to the state people as soon as possible to try to get answers. There's any question you do not want to ask someone, I have no qualms about asking people questions about these systems. So please, please, you know, feel free to ask any questions, large or small, of the coalition, and we will try to get answers for you.
I haven't gotten any yet, but as soon as I do, I will let you know.
Let me know.
And if you want to,
okay.
Yeah, and if you want to make this full screen, you can click on the top.
Oh yeah.
From.
I know.
Yeah.
It actually helps. Okay.
Organizationally wise, yeah, to see.
Yeah. See what's next. Sorry. So I just want to remind people that if you're not actively preparing responses to RFAs for capital funding, there are two. There's the $100 million nonprofit capital investment program. Those responses are due September 29th. And then there's the $30 million statewide health facilities transformation RFA. Those are due at the end of the week. And that was for Article 31 clinics. The $100 million nonprofit infrastructure capital grant is general purpose capital projects for any nonprofit provider. And the $30 million is for Article 31 clinics. So we would like to know if people are applying for these, how many agencies applied, and how much, and what the purpose was for your request, because it will help us shape advocacy around continuation of efforts like this if your programs and your projects aren't funded. So if members feel comfortable sharing that information, I certainly am interested in knowing whether you plan to participate and what type of project and how much you're requesting. For the statewide facilities money, DOH expressed concern that they don't know that they're going to get a lot of community-based applications. I don't know why they think that. The letter of intent option was optional. If it was just that people didn't put in a letter of intent since it was optional, I don't think that that is a good basis. I think that the 100 million nonprofit, people feel that it will be subscribed. Any questions about these funding opportunities or comments about these funding opportunities?
We do have another VBP MCTAC question. Do you know
Sure.
how many Albany MTAC VBP, how the Albany MTAC VBP in-person meeting differs from the 2 webinars?
So I think that the webinars are specific to children's and specifically the United Hospital Fund report on why some specialty VBP arrangements for kids, high needs kids might be needed. And then so it's going to speak specifically about children, whereas the boot camps I think was just, you know, generally VBP. And I got very, very great feedback. I know that Clyde Comstock attended the regional VBP boot camp, and he's been asked now to be added as a panelist by the state to the other boot camp meetings. That they were very pleased, you know, by the level of input and understanding and the ability to make it clearer for the participants. So I do think that people felt that the boot camps were helpful in explaining what this all meant. I mean, it doesn't make you any more comfortable with assuming risk or being able to have the technical expertise to participate, but understanding, you know, the mechanics of it and why the feds have chosen this route, I think is an important first step. Anything else, Nicole?
I haven't gotten any more.
Okay. So we coordinated a small focus group meeting with OMH because OMH recently hired a new staff person who's just going to work on the issue of transition age youth. And OMH asked us to, you know, help introduce that person to the coalition, to some of the coalition's programs and services. We had about 4 agencies represented. The meeting was hosted by the Northern Rivers in Albany. And so we specifically discussed the fact that to OMH, transition age youth is 16 to 21, because for behavioral health, up to 21 is the cutoff. After that, kids go into the adult treatment system. That OMH is in the business of treating people, so we talked a lot about housing options, and OMH was quick to say if the housing model includes treatment, then that's what OMH supports. And then they did allude to the fact that there could be a new transition age RFP for up to $33 million. It may or may not be included in the state budget. It hasn't been cleared, but OMH is putting together a proposal. They would like to focus on the substance-using transition age youth. We came up with the idea that within the new ACT team expansion that is going to be funded through some reinvestment and will also be in the budget proposal, 20 new ACT teams, 15 upstate, 15 downstate, 5 upstate, that they include as a priority the need to provide ACT team component for transition age youth. we got into a great discussion about how the new state plan services can serve youth who have been discharged and are trying to live independently in the community up to age 21. But if you have innovative ideas about other priorities that we should be identifying for this population, now is the time to share them with us, because we can possibly influence the proposal that will come out that has to do with serving transition age youth population. Any comments there, Nicole?
Not gotten any comments yet.
This is a commercial that we were asked to include by the Conference of Local Mental Hygiene Directors. I don't know if you've had the opportunity to become involved in the Regional Planning Consortium, the RPCs, but I would like to just let everyone know that the state included the in the 1115 waiver, and CMS embraced using some of the funding to support this regional planning consortiums because they feel that this is a good consumer protection mechanism. That if the plans are required to participate in the RPCs, then the plans have to hear from consumers, from local government, and from providers firsthand as it's happening, not after data's been collected, but as issues are being, identified in the community. What some of the implementation issues are. There's a little bit of a disconnect because I think the meetings are only quarterly, so I don't know if that's as quick as data would be available, but I do think that it behooves you to be included in the RPCs as opposed to not trying to participate, and I understand the demands of trying to have someone participate. The state trade associations asked the Conference of Local Mental Hygiene Directors, what's the role of us, the coalition, in these RPCs? And we were clearly told that this is a very localized 11-region effort, and it's not an Albany-focused effort. It is a community-focused effort. So that's the reason that I wanted to include this, is that my recommendation is that if you have staff that can participate in the RPCs, especially, and families who can raise the concerns that they're having with the implementation of managed care, that there is value in participating in the RPCs.
Now, Andrea?
Yep.
I think it would be a good role of the coalition to coordinate when these things are occurring, who's involved, and really supporting our members being involved. So I think it might be a place for us to really make sure that they get the support, we get the support we need to meet and to know what's going on all over the state.
Okay. We can add that. I mean, we struggle here about sharing other people's meeting information because a lot of times we'll get questions about a meeting that obviously we only tangentially know about. But I think that this could easily be a website addition where we just continually update the RPC meeting schedule. We'll look into that, Jim. And then, yep.
I did receive one comment from Jeff Shapiro, Andrea. It says we should increase the age up to 26.
Yes, we agree, but unfortunately the 1115 waiver has been submitted, Jeff, and OMH kind of agreed, but it's 21. for the purposes of behavioral health programs and funding the transition age youth with OMH funding, unfortunately.
Maybe we can create a transition age adult from 21
Yes.
to 25.
Yeah. I mean, it was discussed, and I think that everyone agrees that it's unrealistic to think that youth-focused programs should end at age 21. So I just want to quick update. We're almost at the end of our meeting time, and then we'll open it up. We'll open up to questions. But the states. I just want to make an editorial comment. Despite the fact that my screen is not full size, we have managed to get through an entire webinar without any major technical difficulties. State is not faring as well. So the TCM transition to health home webinar was unable to go forward and has been rescheduled to September 20th. I hope people will be able to participate. The coalition had anticipated that we would have follow-up questions for the state on that transition for the quarterly meeting, but since the meeting didn't take place, we'll have to hold off and see what the 20th brings us. We also are, after you hear about what the plan is for the state dollars that will be residual for the non-Medicaid kids that are currently in targeted case management, and then you'll be able to receive those funds through your local contracts in New York City through a contract with the city, upstate in your contracts with the county, how much money that will be, what the program requirements are for the non-Medicaid kids. We've had really good discussions with OMH about the upstate provisions and the fact that we don't want the counties to superimpose a lot of additional requirements. We think that the non-Medicaid health home care coordination program should be as equivalent to the regulations of the health home, whereby there's not face-to-face requirements, there's no staff ratios. We don't want to kill the program because it's a tiny amount of money and too many program requirements, and the state is in complete agreement with us on that, and there should be no problem with the pass-through to the upstate counties. There's some concern that in the city has kind of already indicated what the contract would look like for the non-Medicaid program, and that they have retained some of the old provisions about face-to-face requirements through the Medicaid program in the non-Medicaid program. OMH and the regional office are joining the coalition to do some outreach and education to the New York City Department of Health, Mental Health, to try to prevent that from happening. So we just wanted to make you aware of that, and if the city providers that are TCM providers are getting contracts, we hope you'll be raising concern that the non-Medicaid health home care coordination program should mirror the health home program and not exceed the requirements. Does anyone have anything related to that issue?
I have not received any comments yet.
Okay. And the other, for those clinics that were receiving uncompensated care funding in the past and haven't because of a technical glitch in the process, the coalition has been involved in a lot of advocacy around this issue. And at the DOH meeting on Monday, we received an update about how the state plans to rectify the fact that the uncompensated care funding for 2014 and 2015 has not been forthcoming. So it's complicated. I'm not going to go into too much detail, but basically it requires the state to do some financial take back from the FQMHCs that share our uncompensated care pool, and to match that money after they collect it from Chicane's members, and then to redistribute it to the mental health clinics and the FQHCs. Going forward, we will no longer be in an uncompensated care pool. We will be in a new safety net clinic rate methodology. But the intent is the $55 million that's available in state funds and then gets matched by the federal government for $110 million to be available to FQHCs and Article 31 clinics for safety net care. We'll move forward with some new eligibility requirements. So we are getting the detail. We'll get a memo that outlines the new qualifications for when you have uncompensated care that would qualify for safety net providers to get some funding, and I will share that with you. But just rest assured that we were assured that the 2014 and 15 funding that you may be owed is going to be forthcoming probably before April 1st. Not that soon, but at least you're not going to not get it. There is some question about whether, if you didn't receive funding for 2013, whether that funding would be forthcoming. That question wasn't answered, which leads me to believe that it's possible that 2013 uncompensated care funding will fall through the cracks because of some budgeting flaws that occurred at the state level. Does anyone have any questions about that program?
No questions yet. I just want to encourage folks also, you can raise your hand and I can unmute you if you'd like to make your comment aloud. Okay, I haven't got anything.
Okay, so Jim, do you want to close? I mean, that's really everything that I had, unless you have something else to add.
Yeah, I think what we've heard in our meeting with OMH, that they're involved in complexities that they're unprepared for. I mean, I think for those that got the VAP funding, it's all wrapped up in issues related to upper payment limits and DOH and CMS. And OMH, you know, was unprepared for that. I think with some of the SPA services, again, there are complexities that they're just trying to figure out, one of which we didn't even talk about because it was only mentioned peripherally, but the whole issue of licensing and state education involved in who can hire licensed practitioners that really came up during scope of practice debates is still being discussed related to these issues of SPA services. So there's a lot of complexity, and OMH is on one hand trying to get it right, on the other hand needs to move forward without having a lot of capacity. So it's going to be important that we communicate with each other, that we continue to let Andrea know what we hear, but also what we want her to support in her advocacy of our needs. So with that, I appreciate
Yeah, Jim, I also realized that if the RTF, I didn't talk about the RTF VBP issue, but I just, one piece of information that all of the RTFs should know is that the coalition will have to make a recommendation relatively soon about whether we believe RTFs should move into Medicaid managed care for July 1st, 2017 and January 1st, 2018, or whether or not it makes any sense to hold RTFs out as OMH has committed to hold out CRs and day treatment from that initial movement to Medicaid managed care. And that was presented to the coalition at the quarterly meeting, that decision must be made, and it must be made for all of the same reasons that I described, you know, before. You know, that's going to be in the fiscal year that the budget's being put together for right now. They need to know whether to move that money into the premiums or not move it into the premiums and therefore, you know, this is a budget making decision that has to be made this fall with an initial recommendation, you know, really by the first week in October, but, you know, we'll have a little bit more time. But I just want to make people aware that that decision does need to be made, and I welcome any input that people have about reasons why we should go in, which include we can't do value-based payment arrangements for a specialty population if we're not in managed care, or why it makes sense to hold off. So RTF directors or agency CEOs, please share your thoughts with me on where you would like your agency to be, and then the board will meet and make a recommendation. All right.
I do have one more question.
Okay.
Deidre Sefaraza. She asks, do you know how much flexible funds, service dollars, children in health homes will receive?
So health homes won't have flexible funds, but the non-Medicaid health home will have flex funds at the same level that used to be available, and the non-Medicaid flex funds will be able to be used for kids in the health home. So it's going to be a small dollar amount, but there will be great flexibility as to which children you can use that funding for.
Okay, thank you very much, everybody, just stay in touch.
All right, thanks a lot.